Hello and welcome. Today we're diving deep into the world of Cryptococcus. This is a fascinating organism. It's all around us in the environment, but under the right, or I should say the wrong circumstances, it can become a really dangerous human pathogen, causing serious lung infections and even life-threatening meningitis. So let's get into it.
So here's our roadmap. We'll start with where this thing comes from, its environmental origins. Then we'll cover how we actually diagnose it, and of course, how we treat it. After that, we'll tackle the really critical complications, and we'll wrap it all up with a clinical case review to see it in action. All right, section 1. Let's start at the very beginning. How does a fungus that just lives out in the soil manage to get inside us and cause such a systemic, body-wide disease? Well, the pathway is actually pretty incredible. Cryptococcus neoformans is just out there, living its best life in soil and bird droppings. And the way in? We breathe it in. It sets up shop first in the lungs. And here's the crazy part. That initial lung infection can be so mild that you might not even know you have it. It can be completely asymptomatic. But from that quiet foothold in the lungs, it can then spread, and it has a scary preference for the central nervous system, which is where it causes that devastating chronic meningitis. Now, while technically anyone can get infected, the risk of it becoming a severe, life-threatening disease is not the same for everyone. It really, and I mean really, targets people with compromised immune systems. We're talking about patients with conditions like Hodgkin's disease, people who've had organ transplants, and very importantly, individuals with AIDS. This vulnerability is a crucial piece of the puzzle. So let's say a patient shows up with some suspicious symptoms. How do we actually figure out that we're dealing with this specific invader? This section is all about the clinical detective work that goes into diagnosis. The culprit we're hunting for is Cryptococcus neoformans. It's a yeast, but it's got a special superpower, a capsule. This capsule is a huge part of what makes it so dangerous, acting like a shield that helps it hide from our immune system. It's a risk group 2 agent, which just underscores that it can cause some really significant disease, especially that severe meningitis we keep talking about. The process for nailing the diagnosis is very methodical. You've got to start with the right sample, so cerebral spinal fluid, or CSF, if you suspect meningitis, or maybe sputum if you think it's in the lungs. You can look at it directly under a microscope with special stains, which can give you your first big clue. But really, the gold standard is growing it. We put the sample on Sabouraud agar and wait for about 2 weeks. Only then can we do the final biochemical and molecular tests to be 100% sure what we have.
In the clinic, we're mostly dealing with 2 main varieties, neoformans and Gaddy. But honestly, knowing the variety is only part of the story. The absolutely critical next step is susceptibility testing. We have to know which antifungal drugs, like fluconazole or amphotericin B, are actually going to work. Skipping this step is just not an option. It's totally essential for planning an effective treatment.
And that leads us right into our treatment arsenal. Once we've identified the enemy, we can launch our counterattack. And this isn't a one-and-done kind of thing. It's a multi-phase, multi-drug assault. For meningitis, you have to hit it hard and fast. That first phase, the induction phase, is aggressive. The best practice, preferred regimen, is a 2-week combo of IV liposomal amphotericin B plus flucytosine. Why? Because this combination has been proven to clear the fungus out of the spinal fluid faster and, most importantly, improve survival. The alternative, using fluconazole, well, it's just not as good. The outcomes are clearly less favorable. And after those first 2 weeks, you're still not out of the woods. For meningitis patients, you then move to what's called consolidation therapy, usually with oral fluconazole, for a total treatment time of at least 10 weeks. Now, for the less severe cases, the ones that haven't spread to the central nervous system, the approach can be a bit different. You might use fluconazole by itself, but you're going to be on it for a long, long time. We're talking 6 to 12 months at a minimum. Okay, and just to take a quick breath before we get into the really heavy stuff, a little microbiology humor for you. Why did the fungus break up with the bacterium? Because there wasn't enough space for him to spore. All right, moving on to section 4. You see, a successful outcome here isn't just about picking the right antifungal drugs. It's about expertly navigating the very serious complications that can come along with this infection. Cryptococcal meningitis can cause a whole cascade of awful complications, but the most immediate life-threatening one is elevated intracranial pressure, or ICP. High pressure inside the skull is directly linked to terrible outcomes. Managing this aggressively, often with repeated therapeutic lumbar punctures to drain fluid, is absolutely essential for survival. Other major risks are things like hydrocephalus and permanent neurological damage. This brings me to what is probably the single most important clinical pearl in this entire explainer. So listen up. What is one of the most dangerous mistakes a clinician can make when they're managing this disease? The answer is giving the patient corticosteroids. This is so important. It might seem counterintuitive. You think inflammation is bad, let's use a steroid to reduce it. But in this specific disease, that is the wrong move. The evidence is overwhelming. Giving steroids actually makes things worse. It slows down how fast the body can clear the fungus, and it directly increases the risk of death.
And just a quick note on infection control. Because this fungus is literally everywhere in the environment, trying to prevent exposure at the source is pretty much impossible. So the focus for infection control is really on standard precautions within the hospital or clinic setting.
Okay, time for our final section. Let's pull all of these pieces together and consolidate everything we've talked about by walking through a quick, hypothetical case from start to finish. So let's set the scene. Imagine a patient, maybe an organ transplant recipient, comes into the clinic. Their main complaints are a headache that just won't quit and some confusion, some altered mental status. Right away, you know this person is immunocompromised, which makes them a perfect target for an opportunistic invader like C. neoformans. You start thinking back. Maybe they had a slight cough a few weeks ago, something they brushed off. That was likely the initial subtle lung infection. But the neurological symptoms they have now, that's the big red flag. It screams dissemination to the central nervous system, leading to meningitis, which is absolutely the outcome everyone fears.
So there's no time to waste. A lumbar puncture is ordered immediately. That spinal fluid is rushed to the lab for a complete workup. We're talking an India ink stain, a cryptococcal antigen test, and of course a fungal culture. This is a high-stakes diagnosis that really relies on meticulous work from a specialized lab.
And as soon as the lab calls back with a positive confirmation for C. neoformans, the clinical team knows exactly what to do. They launch that multi-phase assault we talked about. It starts with the aggressive induction therapy, liposomal ampho-B and flucytosine to get the acute infection under control, and that's followed by that long tail of consolidation and maintenance therapy with fluconazole to make sure the fungus is gone for good.
And we'll end on this final forward-looking thought. We're living in this incredible age of medicine, where we're getting better and better at modulating and often suppressing the human immune system to treat all kinds of diseases. But this leaves us with a really critical question. As our ability to do that evolve, how must our strategies against opportunistic fungi like Cryptococcus adapt right along with it? Thank you for joining this explainer.